Hello, my name is Brianna, and I'm recording a presentation on public policies in regards to the 7 principles of public policy that we focused on in our Economics of Public Policies class. Instructor is Kristen Brown. Class number is 115809, Econ 4010, DEA1. My name is Brianna, and the public policy that I will be reviewing is prescription drug pricing reform, and just how sound it is based on those 7 principles. So first, let's talk about the policy itself. There have been many versions of this. Presently, there's a lot of work going on with the basically Medicare price negotiation space. I think that was the Inflation Reduction Act of 2022. There's been a lot of talk on how this is effective for Medicare recipients, but also where can we expand this? How can we make this better? How can, as a system, as a country, can we make this reach further, go beyond just Medicare patients and reach into the private sector as well? The basis of this is reducing prescription drug costs for the end user. It, again, focuses heavily on Medicare, but due to the fact of, drug costs are rising at a monumental rate, it has come to a point where the federal government should and must step in to take point and make sure that, prescription drugs are available and affordable to everybody in this country. So through the 7 lenses, my intention is to look at the principle, talk about how does the principle relate to this policy and, the ideas about making it better, maybe current state. And then if there's something within that space that needs to be expanded on of, how can we fix this based on kind of the results from those 7 principles and what that looks like. Before we step into that, kind of what is the background, right? What is the problem it aims to solve? Who benefits? Who might resist the change? And kind of what does that look like? What are some changes that we can expect? What are some costs we can expect based on this? So again, the problem it aims to solve is drug pricing, right? We want to make sure that things like, especially the big one that I think everybody's heard of, is insulin, right? A lot of people need insulin in this country. We have a lot of diabetes. It's definitely an epidemic. But the cost of insulin is expensive. It's very, very high. And it's something that you truly, need to survive. It's not something that is, an option for most people. It can cause very, very serious effect if you don't have your insulin. And it actually makes healthcare costs for that patient higher. They're a higher burden on the healthcare system if they can't stay adherent to their insulin. And let's say, it's too expensive. It's costing them a couple $100s a month. They decide not to take it. They have a catastrophic event with their sugars. Things like people losing limbs is very, very common with people with diabetes who are not able to manage it. And a huge percentage of those people do struggle with the cost. That's a huge part of why so many patients don't stay adherent, is it's not affordable to them. So that is definitely one of the top, drugs that we'll just talk about because everyone knows about it. It's definitely very much at the front, the front of this kind of why this policy needed to be implemented and why it's being fought for and why it's being amended and why it's being changed. So making sure that we, make those kind of drugs affordable. Obviously, the people who are going to benefit are the end users, through the patients. Currently, this is really geared towards Medicare patients, so seniors, taxpayers. Some of those generic manufacturers could be winners from this because if they're promoting the use of those generics, ultimately you have more power over the cost. Obviously, you've got the big ones who are going to fight this are going to be your your pharmaceutical companies, manufacturers, those brand names. So like example, if we're talking insulin, Novo Nordisk, right? They're big big name, Eli Lilly, those big companies who have the patents on the brand name medication are who are going to fight this. And they do have a lot of financial pull in the political community. So it's definitely something to take note of. So the most recent kind of bill that we're going to talk about is that Inflation Reduction Act. This came in 2022, but its plan is to, again, introduce basically negotiation for those drugs, and it's going to come in waves. So it's not something that just flips a switch and it's taken care of. This looks and goes into plans for 2026, 2027, and beyond, kind of slowly negotiating those prices for those high cost drugs down for Medicare patients. So some of those changes, again, it's gradual. It's not going to be we see it fixed in a year, we see it fixed in a month. It's something that this act definitely makes sure that it's not shocking the system, but also we're going in the right direction. So now let's get into the actual principles. So the first principle, free people are equal and equal people are not always free. So when we think of that, in the case of this policy, we're talking about kind of this, balance of where do we draw the line? We want our free market, like what we currently have. That's something that's important. Being in the United States, we have, freedom of speech. We have the freedom of free market. So as a business owner, I get to choose, right, how much I'm charging my service or my product if I created it. We're kind of in a weird space with that, right? Do we keep our free market as is and allow this pricing to continue to rise and, be a real detriment to society? Or do we step in and kind of eliminate that freedom and make sure that we have affordable access for a very, very large population in our country? So obviously, that's where this policy comes in, right? Do we limit pricing freedom to promote affordability? That's the question. And ultimately, yes, that does need to be a thing. I think there's many things that need to be considered, especially with some of these drugs that they are not, new anymore. They're not having those giant innovative costs that they maybe did 20, 30, 40 years ago. Insulin example, it's been around for a long time. They are coming up with new types of the medication that can target different things. But those base, Lantus, Humalog, Humulin, those things, they've been established. There are well-known generics. They should definitely be able to be affordable for consumers. So I would agree in, my takeaway from this is that limiting that freedom is worth the cost to promote affordability amongst a very large, patient population. Principle 2, what belongs to you, you tend to take care of, and what belongs to no one or everyone tends to fall into disrepair. So when we think of this program or what this bill, who they're looking to affect, it's Medicare patients, right? Medicare is a publicly funded program. So when we talk about that, it does belong to everybody. Everybody pays into Medicare on our taxes. It is a system-wide program. And hopefully the outcome is that if we need it, anybody who's paid in can garner benefits from that program. So this is, again, kind of one of those what everyone owns tends to fall into disrepair is, potentially the downfall of this. But we could also look at it through a different lens, right? If we make drugs more affordable, it kind of puts it, and it provides not only, the people who are kind of enforcing this law to have some stewardship over, public funds, it also will have those adherence rates go up. And that's also very, very important. So not only is who's running the program, but if you have people who are using it effectively, they're going to be more vocal about its success and, how they need it to be successful. So that's kind of the downside, or the upswing of principle 2 is that, yes, while it's public, having this will actually help people stay and do what they're supposed to do and take some stewardship over the program. Principle 3, sound policy requires that we consider long-run effects and all people, not just short-run effects on a few. So if we look at what the long-run effects are, short-run effects are, any risks, kind of balancing the two, these are the things that stick out. Long run, what are we going to do in the long run? Overall, Medicare patients will save cost and ultimately, hopefully, be able to afford medications that they need to live a quality of life and have a certain quality of life. This could also improve access. So people who, again, right now, have completely just decided, nope, this is not something that I can afford or do or be part of, they can be part of it and, again, increase studies, increase usage. We get more data, the more people who ultimately have success on these therapies. What is a risk? A risk could be something like innovation slowing. When pharmaceutical companies are not necessarily seeing that big paycheck that comes from some of these types of drugs, they are less likely to invest their creative teams, their innovation, their scientists. They might go towards higher paying, maybe more niche studies, which is ultimately, not really serving anybody, but at the same point, there may be other ways to combat that risk. Something like tax incentives for innovation could be an outcome of that. Or again, having some sort of other financial benefit that maybe doesn't affect the patient themselves, but it can benefit the company to keep innovating in those spaces, even if maybe those drugs have been the pricing has been negotiated down. So there are other things to consider there, but that would be your risk. So it's, again, finding a happy balance. How do we, again, provide savings and access while also still incentivizing innovation? Those are our two big factors with this bill. And again, I do think there are other ways to do that. Principle 4, if you encourage something, you get more of it. If you discourage something, you get less. So in the sense of, again, we've talked a little bit about adherence, right? We want this bill to encourage in the scope, like, let's look at this in two phases. You've got your benefit to the actual patient and the end user, but then what is the perk that makes this policy, agreed upon through not only Medicare users, but other users, people who are actually implementing the bill, and then ultimately manufacturers and pharmaceutical companies as well. You want there to be the balance so that everybody can get on the same page that this is good moving forward. But talking from the patient perspective, if we encourage it, we're going to see more of it, right? If we can get those prices lower, we're going to see more use. So even though your cost is lower, we're going to have better adherence rates. Overall health burden on, health systems will be lower because, again, we know it's studied and adherence rates are monitored heavily by hospitals, is that if patients are adherent to their medications, ultimately in the long run, those healthcare bills go down because they're not using critical services like the ER. We're not having long hospital stays. We're not having catastrophic events that can turn them needing, long-term therapy. Again, let's use the insulin example. You lose a foot. Ultimately, you then have to go to, you have to have the surgery. You have to have the procedure. You have to recover. You probably have to go to therapy. So those burdens actually add up. Had they just had access to their medication, maybe could have avoided that entire cost. So we're talking prevention in the future of costs. So we're encouraging that. So that's affecting more than just the user, like we talked about. It's affecting the hospitals. It's talking the insurance. It's talking about probably even pharma in the long run, because ultimately, even if we're making it less costly, they're going to have repeat fills of those meds. So yes, they're more costly. They're charging a little bit less, But hopefully the result is more patients regularly filling those medications and the insurance billing for them. So ultimately they'll have a better rate of bill. All right, principle 5, nobody spends somebody else's money as carefully as he spends his own. So in this, it does speak to the patient side as well of who's really the beneficiary of this bill. Obviously, we are very careful, right? And if there's something that needs to be cut, a lot of patients, that's their bill, that's their meds, right? Should it be? No, but if it's that or losing their home, putting food on the table for their kids, paying the electric bill, those things most of the time supersede the upfront need for this medication. Now, I mean, some people will tell you differently, but I think overall there have been studies that I've read that at least 30% of people who are taking these high cost medications do say that they can't take it because it just isn't affordable regularly for them. So it's definitely something that, yes, if it's me and I have to pick one of those, critical things to survive, that might be the thing that I've dropped for a month. Definitely being a parent, that would be a very, very difficult decision. But when we talk about this bill, it's this one's kind of hard to, or at least for me, it's been hard to put a finger on how this principle really, really ties with the bill itself more than the actual users of the bill. So again, maybe what also results from this and what I've found is that maybe these negotiations aren't in alignment with like consumer preferences. And obviously, again, I think really this one hits more on the actual client who's receiving it more than that, but that's all I have for principle number 5. Principle 6, the government has nothing to give anybody except what it first takes from somebody else. So when we talk about kind of that balance, right? I mean, that is ultimately what our government here is here to kind of be the equalizer. It's kind of here to balance and provide oversight. It's here to ultimately help its people. It is not here to dictate the people per se, but it is here to service us as a community and as a whole. And while, yes, what we're doing here is I think the give and take between two different groups, right? You have the give to the consumer, the Medicare patients, those, people who maybe can't afford private health care. Those patients are who are getting the benefit. Who are we taking the benefit from? We're taking it from pharma, ultimately. And that has been a topic of discussion in a lot of like our big presidential elections, right? They're always talking about, I'm going to, talk to big pharma. We're going to get them down. We're not going to have them pay as much money. But ultimately, we don't see a lot of progression from that. We don't see a lot of outcome. It's definitely a big talk. Nobody, I don't think really anybody, if you asked, was like, yeah, I'm pro big pharma. They're not. Big pharma is a monster in its own. They do, they make a lot of money. They have a lot of money. So in this situation, I think everybody can agree that where we're taking from, it's worth kind of that, risk in the principle. We're taking it from someone who has really manipulated the system for a very long time. They've had a lot of benefits that have gone into, again, all of the laws that basically give them that patent right for the first 10 to 20 years, depending on their drug. And that helps them recap and regain all the costs and the fees that they've spent to create the product. But there is a level of that going too far. And I think that it is, again, worth kind of, that's the evaluation from the principle, is if we're taking it from big pharma, we're giving it to the end user, those Medicare, those high risk patients, it's worth having it be taken from someone else, in this case, someone else. Principle 7, liberty makes all the difference in the world, right? So we're talking about that true sense of freedom. And here we're really talking about that free market and that pricing. I think here we talk about what is on the scale worth more, right? What's more important? And I think this should be kind of dependent on the sector and how much that goes, because if we look at the drug costs, it is substantial, and they've been increasing at a substantial rate for a very long time. And who's really seeing where that dollar goes? It's those big pharmaceutical companies. As much as I, again, am very pro innovation and pro new therapies, I think that's the only way we're going to come upon cures and change for those really high risk populations, like let's say cancer patients, neurological disorder patients, things like MS, things like Crohn's disease, different things that really affect people's daily lives. And we want continued innovation. And I'm very, very pro innovation and actually making sure that there is incentive to still create and push boundaries and look for those cures and those things that are going to save a lot of lives and a lot of people. But there is also kind of that line in the sand, that gray zone, right? In my opinion, based on this principle, is that the downsizing of the liberty in that kind of market space for drugs is worth having expanded health access to patients who need it. And again, there's a fine line and there's a balance, and there are other ways we can maybe recoup and provide incentive for these manufacturers and these pharmaceutical companies, but there's a limit. Like, yes, it's the sky, and we want to believe that anybody can become and have $1 billion, right? That's the American dream, is you have this ability to create and, have monumental wealth. But also, I think this has gone too far. There does need to be major change, and we will have to limit that liberty in the sense of the manufacturer and those pharmaceutical companies and free market. So overall, just as again we've touched on, what is the policy? Who is it aiming to help? Current state. What are those 7 principles? Kind of how do they relate? As a conclusion, I want to just give kind of and I've provided it throughout, but my overall view of this bill, based on this class, based on the discussions that we've had, and also just what are some other potential, outcomes. I've read this really, really good article from Stanford, and I'm trying to find it to pull it up here. And it's from, I'm going to pull up the link. It's from the Stanford Institute of Medicine. They have a really good page that they have different writers from their institution, different teachers, educators, healthcare professionals go on. And I found this really great article, and it's called Policy Options to Reduce Prescription Drug Costs Across Medicare, Medicaid, and Commercial Insurance. So this Dr. Patel writes kind of his opinion on what are some additional things we can do to create some savings in this huge industry. And he gives some really good statistics. So he says basically that according to the 2024 RAND study, prescription drug prices in the US are on average 2.78 times higher than in 33 other OECD countries. And even with just this, the first 10 drugs selected based on the Inflation Reduction Act of 2022, it's projected to save $6 billion in 2026 alone, and which is a 22% reduction in spending across these medications. and that Medicare beneficiaries are expected to save $1.5 billion out of pocket in 2026, which represents a discount of 38 to 79% off of the list price. That's monumental. That's huge. But again, those cost savings are only going to be seen by those Medicare, Medicaid patients. They're not going to be seen by private insurance. And, typically, depending on your private insurance, they can be more reasonable. Again, it's highly dependent on the insurance and the plan that you chose. But there are ways that he's suggesting, right, to make this better. What can we do? Some of the options he gives is basically extending those negotiated prices that are, currently going to Medicaid, and then expand them to commercial plans. That would amplify the savings. So not necessarily expanding the list of drugs or like how many more he's going to do. Obviously, they're starting again with those 10 drugs. They're going to move on from there. But with that, not just reaching Medicare patients, but commercial patients as well. That's a huge amount of patients that they could help by kind of changing the way that this bill is tailored to, again, how can we make this be more wide reaching in the country and help more of, more people. And ultimately, this could save them money. So when we think about our Medicare patients, they're usually seniors, they're disabled, they're kind of in that second maybe phase of their life. Commercially insured patients are more like young families, maybe kids out of college, things like that. They're in their early part of their life. And we talked about adherence, and we talked about how adherence actually is so tracked because it does affect kind of the healthcare costs as a whole. So we can have younger patients who, like, let's say, again, we're sticking on the tone of diabetes. Maybe they're 25, they get diagnosed. Maybe it is really expensive for them, and they still are like, yeah, you know what, I feel good. This hasn't affected me so far. Maybe I can put off, taking medications, right? What do we see in the long run? Deteriorated health. Their outcomes are not as great. They could have a catastrophic event that leaves them in the hospital or leaves them with some major long-term effect. Things like that cost the health system millions and millions and millions of dollars, and ultimately make those costs go up. So if we can save costs by, again, providing better access to not only the Medicare users, right, but those commercial insurance users, those young people who should be starting therapy, ultimately, hopefully, by the time that they are in Medicare, they are well regimented, their health is managed, they're living well. We don't have to have such crazy catastrophic bills in the long run. Again, but something to, think about. Prevention, if we talk about cost, prevention does lower use and lower cost. And who doesn't want that to happen is those big pharma companies. They don't want to necessarily see you healthy, because if you're healthy, you're not going to them for their, medications or products, because most of the time they don't just manufacture medications, they'll manufacture a drug product as well. So things like for diabetes, CGMs, test strips, all of those things. Maybe if you're more well regimented, you're using less, right? Or if, again, they're also providing inpatient products, so into the hospitals, if their big bill is, we're providing this much product to hospitals, in the long run, if we have less people needing to go, ultimately, again, it takes away from bottom dollar. So anyway, this article is really, really good. He says a lot of really good information of kind of ways that this program as itself stands and what it's winning at, but how could it be bettered? And there are definitely a lot more and a lot of reform that this entire structure in our system, in our country, could use. And it's good to see that those big names and big research are pouring a lot of time and effort into this. So that is the end of my presentation. I hope you all have a great day.